Welcome back to PedsCrit. I'm Zach Hodges, a pediatric ICU fellow from UT Southwestern in Dallas.
And I'm Alice Shanklin, a critical care fellow at Children's National in Washington, D.C.
Well, Alice, we have part 2 on the episode today. Remind us what we're talking about.
Yes, today we're going to get deep into the nuance of CPR. We're talking about metabolic derangements, electrophysiology, and maybe most importantly, controversies in pharmacology. Zach, who are we speaking with today?
We have Dr. Tarif Choudhury back with us on the podcast. He is a dual-trained pediatric cardiac intensivist at Columbia University. He is also a simulation enthusiast, and he's very active in simulation there at Columbia, and we are so excited to share with you on the pod.
Yes, and we are grateful to Gav Apfel for coordinating this episode. Gav's a CICU hospitalist at Columbia. He's starting his PICU fellowship with them now, and we are lucky to have him on the team.
Yes, let's get right to the episode. Our patient is a 6-month-old male admitted to the PICU, intubated, bronchiolitis, becomes severely agitated. He self-extubates and suffers a cardiac arrest. The team starts high-quality CPR. You come to the room in a concerted effort with bundling of tasks. You get an artificial airway replaced in, but the patient remains in cardiac arrest. You have high-quality CPR ongoing, and then Gav's going to give us our question.
Are there any specific tracings or numbers on the monitor that you make sure to keep your eye on to inform you while the code's going on that our interventions are working?
As the ICU, I'd love some luxurious physiologic surrogates and physiologic data, right? So I know, and for my team, the data that I'll be looking up at the monitor for to suggest that we have high enough quality CPR that's still ongoing as I figure out how to get us out of this jam are the following, and that includes a diastolic blood pressure. And this might be an opportunity to also quickly review what we think we know about diastolic blood pressure. And again, it's tough to talk about this without incorporating the work of the resuscitation leaders in our country and in the folks in Philly as well. To talk about the diastolic blood pressures above 25 and 30 being associated with more favorable outcomes. There was a time where obviously CPR had such a dismal outcome that mortality was as high as 90%. Now we're at a place in the world where in the pediatric resuscitation arena, you can have survival as high as 40, 50, and even 70%. And diastolic blood pressure is one of those things that have changed outcomes. So if I have an arterial line, diastolic blood pressure greater than 30 is one of the numbers I'm looking for. Other numbers I'm looking at, Gav, are if I have an end tidal after that advanced airway has been placed. And by the way, don't just make an assumption that end tidal will be part of the bundle, especially depending on where you're working. It's still a little bit of a work in progress to get end tidal across everywhere. We're almost there. But I've been places where you got the advanced airway and the surrogate of the airway being in place was just something as simple as capnography, or as the board suggests, the gold standard still being, actual auscultation. But for my heart rate to come down, I want to see an end tidal.
Yeah.
And so make sure you ask. And if the end tidal's there, adult data suggests, of course, that end tidals less than 10 have poor outcomes. Unfortunately, we haven't been able to obviously see end tidals greater than a certain number that many of us are taught to ask for, being greater than 15 or 20, to be associated with favorable outcomes. But it's still a number I ask for. I still want to shoot for the stars. Let's aim for an end tidal greater than 20. I'm seeing here, guys, the end tidal is 10. Let's see what's going on with the CPR. Do we need to change it out? Do you think there's something else going on with the disease process? Am I missing something here? Is this the BT shunt patient you're talking about? Is the shunt occluded? Or is this the kid who just came off of CRRT who's having problems with their line because there was clotting all the time? Is this a PE? And so end tidal less than 15, or again, I'm shooting for greater than 15 to 20. Diastolic greater than 25 to 30, because that actually changes and associated with outcomes. And if I don't have either of those, because oftentimes, especially if it's the floor patient who doesn't have those physiologic parameters that I can rely on, then I'm going to just go back to basics. Let's look at that pulse ox waveform, right? Do I have a good peak systolic upstroke? Not to say there's a number I can shoot for, but if the SAT's picking up and I have a good peak systolic upstroke, in addition to the fact that the ZOL, if it's an adolescent or pre-adolescent, the ZOL can tell me I'm getting good feedback, which that's a performance parameter from the compressor, but at least it's supporting the performance parameter by the compressor. Another piece of physiologic data, which I don't have a number to put on the pulse ox pleth, but I see a good pulse ox pleth, and that's good.
It seems like we have a number of options to gain more information about our patients who are undergoing CPR, whether it's just a pulse ox pleth, seeing a spike corresponding to the compression, or perhaps an arterial line where we have diastolic blood pressure targets to optimize coronary perfusion pressure. And then what's I think most interesting is end-tidal CO2 and monitoring that trend, even though we don't know exactly what absolute value is, I wouldn't say predictive of a better success, but if we see an increase in end-tidal CO2, that usually is reassuring that our compressions are good.
Ooh, I have to ask, Dr. Choudhury, are you getting gases during your codes? And if so, how are you coordinating that? Because I so deeply want a gas at every code, and I have yet to land that during compressions.
Well, Alice, going back to the team dynamics and eye on the prize, I got my orchestra playing so well. The last thing I want to do is distract them. If I can get a gas without distracting them, I'm interested. So again, if I put everyone in position and that nurse that was on, going back to where everybody was placed to perform optimally, if that nurse, he or she was on vascular access and can easily get to the arterial line, or if there's an extra person, maybe the arterial line's on the other side, but can easily access the arterial line, why not get a gas? If especially I'm in the third part of my CPR phase, the metabolic phase. And again, I keep mentioning this, but I should probably at least reference where I learned it from, at least. I remember hearing it from some of the resuscitation giants that had taught us that these three phases of CPR, the electrical, the mechanical, which is the high-performance CPR, and now you're 5 or 10 minutes of each of those phases. Next thing you know, this is becoming a longer phase of CPR. I'm in the metabolic phase. I'd love to know whether or not there's a metabolic derangement that I can reverse. The H's and T's that we learned when we were in residency, right? That gas gives me access to the glucose, especially if it's a neonate. That gas gives access to calcium, especially if it's a neonate or DeGeorge. That gas gives me access to the PCO2, all comers, and how well the PCO2 is corresponding with the end tidal, whether or not there's a delta. That gas gives me the PCO2 and whether or not I picked 20 where it should have been 30 for the ventilation rate for the kid who's had a respiratory arrest, right? That gas gives me access to the kid who was on CRRT that I showed up to the arrest to, whose K is actually 7. And that's why this is a VT arrest. Because if I can shock till the cows come home, but if I don't change the underlying mechanism of the VT, I'm going to keep going back into VT, in which case it'd be nice to recognize whether or not the potassium needs to be reversed, right? So I'm a proponent of gases. And sometimes it can also give you a glimpse into how this code is going in case, unfortunately, you have to have difficult decisions later on in the code about whether or not this code should continue.
Yeah, lots of handy information there. I'd like to ask a question about pharmacology in a cardiac arrest, and starting off with what we use each time we have an arrest, epinephrine. And tell me this, what makes epinephrine such an important medication or such an advantageous medication for an arrest? Do we use it because it's better than other medicines, or we use it because we've always used it?
Well, depending on who you ask, it's both, right? Yeah. Whichever companies you have stock in, whoever took you out to your last steak dinner. But, back to the North Star, if it's about coronary perfusing pressure, you need to have your systemic vascular tone up to snuff to have a good diastolic blood pressure to drive coronary perfusing pressure. Now, what's the right drug? Is there a drug that actually does it? Is this your body's endogenous sympathetic tone? Tough to say. Most of us ascribe to the philosophy that it is some exogenous drug needs to be administered for some period of time. What's that period of time? Also difficult to say. How often? Difficult to say. But if you at least ascribe to the North Star, which is the physiologic principle of coronary perfusing pressure, then epinephrine makes sense to try to drive your systemic vascular tone. Are there other drugs out there? Yeah, of course, there's vasopressin. There's phenylephrine. I'm yet to see phenylephrine necessarily in a code, but I have definitely used it to stave off codes. But vasopressin at least has been discussed in the adult literature, and whether or not it could be equivocal, maybe even superior to epinephrine in its use during an adult cardiac arrest. In pediatrics, we have yet to demonstrate one being superior to the other, in which case, if you revert back to the PALS algorithm, epinephrine makes sense. Personally, as a cardiac intensivist, I've started to wonder, at least. I'm not going to pretend to say to you I've had the courage to administer this principle just yet, but I can say with honesty that I've asked for it. I've never had to administer it yet. And I started to wonder now, about 6 years now into being an attending, if certain lesions, in particular pulmonary hypertension, the pulmonary hypertension patient who arrests, epinephrine till the cows come home is maybe doing you some harm. Because if you're providing a vasoconstrictor, which doesn't care which vascular bed is vasoconstricting, you start wondering whether or not you can have a little bit more of a selective vasoconstrictor in the form of a vasopressin bolus. And I know this is going to be on air, and many people are probably going to email me and say, you're starting a movement that is uncalled for. This is inappropriate. I'm just trying to create some provocative thought. And in fairness, it's provocative thought that was generated by people that are much smarter than me that I'm just sharing. So you at least wonder whether or not maybe there's lesion-specific opportunities for vasopressin. Otherwise, it's pretty equivocal.
Interesting.
Yeah, that certainly is fascinating. And it physiologically makes sense. If you want a drug that gives you good systemic vasoconstriction but spares the pulmonary vasculature, vasopressin sure would make sense.
Okay. But you also mentioned not confusing your team. And if I'm at the bedside of an ex-preemie who's intubated for bronchiolitis and I ask for a vasopressin bolus, my PICU nurses are going to be like, what the heck?
Alice, you're totally right. And if you go back to the North Star, and that is keeping my team playing great music, I don't want to distract them, right? In which case I need to mitigate distraction to provide anticipatory guidance. And again, this is a crisis resource management principle. Summarize and re-summarize. We're 20 minutes in. We've given 5 doses of epinephrine, and I'm not seeing ROSC, and I'm still seeing PEA, actually asystole. This is not working. I'm thinking about doing something different. We're going to try 1 dose of vasopressin on the next compressor switch, which are still 2 minutes away. We're obviously going to bundle the compressor switch with a pulse check. We're going to see if there's a dysrhythmia that can reverse all this. But otherwise, can one of you guys that is not doing anything else that's currently super important, because I don't want to distract the person who's drawing up the epi, because that is tried and true. But the rest of you guys, one of you, can you do me a favor? Charge, can you find somebody to go ask pharmacy what the vasopressin dose? Because number one, I don't know the vasopressin dose. So someone needs to offload my cognitive load because I don't know it. I don't need to load up another nurse who's already drawn up the epi with that cognitive load. So if we're fortunate enough and your care model actually allows for the pharmacist who's actually already there to maybe even look up the vasopressin dose and maybe even draw it up for everybody, and there is total unburdening of that load, maybe I could keep the music playing and just add a new potential tool to the group.
That's great. Yeah. Gav, will you cap off this area of controversy with an even more controversial question?
Totally, yeah. Can you talk to us about bicarb? Why do some people hate it? Do we use it? I've gotten a lot of mixed messages, and it would be nice to know.
The reality is bicarb, it's one of those things, right? Resuscitation science, you'll have a hard time finding randomized control trials, right? We all know the levels of science that we're supposed to ascribe to. And if you have randomized control trials that can at least contribute to a meta-analysis, you can say, I've got a meta-analysis that's worth hanging my hat on. We won't have that obvious luxury. So is there a role for bicarb? I think it depends on the lesion-specific resuscitation, right? So if you're taking care of our patient, the patient with the respiratory-mediated cardiac arrest, who's probably got a PCO2 up to the clouds, you started wondering whether or not it's going to have a truly metabolic derangement or metabolic-driven acidosis, otherwise known as base-deficit-driven acidosis. You start wondering whether or not that patient really deserves much bicarb. But in the cardiac ICU, I love passing out that bicarb. Now, I know a lot of naysayers and a lot of folks, a lot of resuscitation scientists, again, emailing me. So I'll have the vasopressin folks emailing me and the bicarb folks emailing me. So I think it deserves at least an opportunity to review what we think we know in the literature. And at least what we know from Katie Cashin's work, from secondary analysis of some of the kids that we get with the guidelines research, which revealed there was an association with bicarb administration and mortality, in which case there's caution with willy-nilly throwing around bicarb. Again, I think you need to be thoughtful about your lesion, right? To show up and blindly, without an arterial line, without gases, without a good sense of what this patient just arrested from, who's the patient, what is the current metabolic state the kid is in, and just throw around bicarb. Yeah, I can see totally why mortality will skew towards blind resuscitation. But thoughtful resuscitation, maybe this is a hypertroph who had systemic LV outflow tract obstruction acutely out of nowhere or VT out of nowhere. Base deficit before the arrest was -7. We didn't do anything about it acutely at the time. We just missed the boat. Bicarb, let's give it.
Is it fair to say...
I'm ready for the emails from the bicarb naysayers, though. One more caveat to that, Zach, is if you're going to give bicarb and you have access to those gases, please make sure that your calcium is normal first before you give bicarb, because we know from the ionic changes, there's going to be changes in your ionized calcium from bicarb administration. So also before you give that, you really want to make sure that your calcium's up to snuff. I know there's going to be more emails from the calcium people now, right? I've got 3 groups of emailers emailing me probably soon.
Oh, and potassium as well. It'll certainly drop your potassium, correct?
That's right, Zach. Thank you for that.
Everyone's chiming in.
Yep.
As a way to cap off this segment, is it fair to say if a patient's going to benefit from bicarb, it's probably a patient who does not have a primary respiratory arrest, or they probably have a metabolic acidosis, and they have a reliable airway that you can ventilate all of the generated CO2 that you're going to get from giving that bicarb bolus. Is that fair?
You're totally right, Zach. I think that's such a great caveat. Even to the metabolically deranged kid who needs his or her bicarb, I'll still need to achieve a method of blowing off that bicarb.
Yeah.
All right. So as we move deeper into the electric side of things, how do we place the pads without disrupting the compressions too much?
Task bundling, Alice. The orchestra's playing.
Task
Bundling. The second flute is taking a break. First flute is going to go ahead and bundle the pads with the next compressor change. A big proponent of task bundling. But again, it requires the shared mental model across the recorder, the team leader, and the CPR coach to be able to provide that anticipatory guidance to the team that's going to bundle those tasks. On the next compressor switch, we're going to go ahead and place the pads. They're going to be front to back. Just do the pulse check and go ahead and place the pads front and back on this neonate. On the next pulse check, on this adolescent, we're going to do a sternum and apex on the next compressor switch, which of course, sternum and apex probably will have a shorter CPR pause. But front to back, it becomes even more important to have a task bundle. And then, of course, there's the nuance of the cardiac ICU, which is where the pads go.
Yes.
So if it's a dextrocardic kid, just want to make sure that there's a reminder in the room and share your resources, crisis resource management. Turn that cardiology fellow, cardiology attending. Can you remind me, is this heterotaxy dextrocardia or not? In which case the pads go on a different location, right at the chest as opposed to left of the chest. One more pearl, and I'm not great at this yet. I'm still working on it personally. If possible, and again, check with your local centers if it's going to screw up your ability to gather meaningful data onto your telemetry. But if you can displace the surface leads on your chest onto maybe the extremities, that will still provide the cardiologist with meaningful data to recognize the dysrhythmia, but at the same time place the pad on so you don't end up losing data completely, because we've had too many of those things happen where the Zoll pads go on the same place where the telemetry leads are on the chest. Next thing you know, one thing costs you the other. I'd like to have both. I like the ability to be able to interpret the data, not just on the Zoll monitor, but let's empower our colleagues to be able to be high-performing contributors. And let's get the cardiology fellow, cardiology attendant to go over to the tele station, be able to look over there as well, in addition to the Zoll, with more than one lead, what's going on. Because yes, they can look on the Zoll for the dysrhythmia and what it might be, but wouldn't it be nice for them just to be able to go over to their tele station as well and see that? One way to continue the ability to do that is to see if we can displace the leads. Easier said than done. When my heart rate's cooking, I sometimes forget to ask that. So that's something that I've been wondering for myself. If I'll lose too much meaningful data by doing that, I don't think so.
That's an incredible pearl and something I've never even thought of or knew it was an issue. But I'm sure if my career goes long enough, it certainly would pop up. So thanks for sharing that.
Too many times in our Zoll card and our debriefs afterwards, we've noticed we've lost the tele data. Coincidentally, it happens to be when we place the Zoll pads.
Yeah.
So for shockable rhythms, definitely the mantra I heard in residency was you start at 2 joules per kilo and then you go 2, 4, 6, 8, and then you go up to 10. Is there any situation where you just, you'll shock, it doesn't work, and you jack it up straight up to 10, or do you typically follow that stepwise approach?
I can't think of a scientific reason I had to go from 2 to 10, Gav. So I guess the methodical in me is going to go incrementally up. I think more importantly is wondering what's actually going on, that electrical treatment is not actually reversing, in which case with each incremental increase in charge, I need to also be turning to my pharmacist and the rest of my team and saying out loud, I think it's time for an antiarrhythmic. Every time I do this, we are not having any resumption of sinus rhythm, in which case I think this is what's going on. Now that we've displaced those leads and I have 3 leads over there, can cardiology tell me what you think it is? Because I think this is VT or VF, in which case maybe it's time to, Coke and Pepsi-wise, pick amio or lidocaine.
Yeah.
For adults, do you use the 100, 200, up to 400 joules paradigm?
I think so, Alice. I haven't really thought of it any more deeper than that. I've yet to deviate from that, I'll be honest with you. It just becomes a little bit more important for me to think about this is not working in and of itself, in which case try something different, and that's going to be concomitant administration of an antiarrhythmic. Especially when the antiarrhythmic kicks in, the next thing you know, and again, this might be the bias of a cardiologist in me, but by changing the dysrhythmia milieu, I may have more success with the next shock.
You need to alter the substrate.
Alter the substrate. There you go. Yes.
Something I'm fascinated and frankly jealous about is how facile cardiologists are with ultrasound, with all the training they get in echo. And I'm just wondering, what is your go-to strategy for incorporating point-of-care ultrasound into the evaluation of a patient in cardiac arrest?
The practical application of ultrasound during a cardiac arrest is when I'm in that out of the electrical, about to leave the mechanical into the metabolic phase of CPR, nothing's reversing, especially for the PEA or asystolic arrest in terms of reversible lesions, trying to identify pericardial effusion or tamponade physiology. So luckily, as a practice, pediatric critical care medicine become more and more facile and incorporate POCUS into our training, we will hopefully all be able to have that power of placing a probe and identifying a large pericardial effusion. So that's my current use, practically, of ultrasound during a cardiac arrest. Otherwise, pre-arrest, of course, it's always helpful to try to identify what you think the child is having their hemodynamic embarrassment from, whether it's a volume issue and just looking at POCUS-wise, the IVC and its collapsibility, or the LV function. But in the arrest, it really just is about function. And sometimes it can help me, I gather some information, although if I think about this out loud, it's not meaningful information to see any real cardiac movement, because at the end of the day, if it doesn't translate to an actual pulse, it's not an alive patient. And there have been studies trying to identify whether or not we human beings are any good at actually palpating a pulse. And if you're not quick enough to think about a Doppler, because people have looked at swapping out our fingers for Dopplers, another way to wonder whether or not there's better activity than you're actually feeling is maybe cardiac ultrasound. But again, I don't need a fifth set of emailers telling me that cardiac ultrasound should be used to tell you that you're okay and you have ROSC. That is not what I mean. That is not what I mean.
Yeah.
Okay.
But
You bring up good points. As a trainee, I wonder if using an ultrasound to visualize pulsation in the femoral artery is helpful. Like, I wonder if that's worth seeing. And I also wonder if seeing cardiac activity during the pulse checks, I wonder if that's helpful or not. And, this is more just me inquiring and thinking of questions and hopefully reading about it in the literature in the days to come. And I wonder how different will be our management of cardiac arrest in the coming years in the pediatric ICU.
Yeah, exactly. If I were to explore this idea out further, I'd wonder whether or not it could be helpful in portending outcomes at most. But at the end of the day, I don't think it changes our management in the middle of the arrest. We have a pulseless child.
Yeah.
And unless you lost your own feeling to your fingertips, still rely on your fingertips. Because at the end of the day, whether there's a pulse or a thready pulse, I think it becomes pretty similar in what you should probably be doing next, which is, as Betsy Hunt would say, get your hands back on that chest.
That's right.
so if you're not lucky enough to look up and see that pleth starting to come back, when do you start to think about calling a code? When would you start to think about wrapping up?
Yeah, I think a lot of it depends on, again, lesion specific, right? Lesion specific, family specific, ICU specific, right? What does the unit know about this patient that maybe I don't know as the on-call attending tonight? What does the unit that I'm being called down to know about this patient that I don't know? BMT patients are a great example. They know these patients inside and out about what the family has wanted, what the patient has gone through, what the unit has gone through, about what they want to see go through for this child. It turns out this is my one call in 3 weeks, and this patient has had 5 cardiac arrests in the past week, and they're always 3 minutes long, and we know what's futile here. And it just so happens that the mother or the father weren't at the bedside to be able to see the other ones. They're here now. They're able to see for themselves what's actually going on, and that can help maybe frame what this code needs to look like. Again, pretest probability of what the code looks like, what it needs to look like, right? And so I'll start off with the duration of a code for when you have an out, for example, ECPR, which a lot of the times the cardiac ICU may have an out because it may be a residual lesion, that if you can get the kid onto ECMO soon enough, even if it means, unfortunately, and many of us have out-of-house ECMO programs where the team has to descend upon the patient in the dead of night from home, you may have to accept an hour-long arrest. We may have to accept a pH of 6.8 or 6.9 when we put the patient on ECMO, and there's no obvious data to support an obvious pH that portends poor outcomes. We know for sure that lower pH portend worse outcomes than higher pHs, but the pH that says you shouldn't go on, we haven't been able to identify that pH yet. In which case, if the shared decision between the medical and the surgical team is to go on, then the duration of this arrest will be that hour. If you have the luxury of gases throughout the arrest, use those gases to figure out whether or not the duration of this arrest, the 60 minutes, should be concluded with actually going on to ECMO. Or does the medical team and the surgical team agree, look at these pHs devolve over time. We haven't had one pH above 6.7 and the patient's pupils are fixed and dilated, although that's obviously room for a lot of controversy also. If you're given all that epi, maybe you don't expect anything but fixed and dilated. I don't know. There's been a lot of debate about that too locally in my place. But I know the cardiac ICU is a little bit more forgiving because of the potential for residual lesions being reversible if you get the kid onto ECMO, or just post-pump slump that needs some more time on ECMO that just wasn't recognized in the operating room, in which case duration may be 60 minutes. Outside of the cardiac ICU, that nuance that I think you're referring to, Alice, which is I don't have that out, and I need to start wondering how long this is going to go, it really depends on some of those things that I mentioned to you. Where is the family at? Where is my team at? Where's the disease at? And I think one of the important members of the orchestra that we didn't talk about as we talked about this performance was including a member of the team in addition to the social worker that's really dedicated to at least shuttling back and forth with the medical team and the parent. Because the parent should not be hearing for the first time that their child is dying 40 minutes into the arrest. The parent should be hearing that the child is dying and using those words and very forward and deliberate early in the arrest. What you're seeing right there is CPR. Your child is dying. I'm so sorry to inform you this. Obviously, there's different ways to incorporate that. The palliative care people are much better than I am in using the right language. But for the most part, I have some terrible news for you. What you're seeing over there is your child is dying. We're artificially keeping him or her alive and getting a sense of what the family's wishes are. If they've been through 5 codes already, the team's been through 5 codes already, incorporate some of that palliative care language. Many loving families don't want to see their children go through something like this. We want to honor the way you love your child and whatever would be most helpful for you to have peace in your heart. We can stop what we're doing right now. Your child is dying and we're just keeping them artificially alive. If they need to see that longer arrest, at least the discussion has started. Right, Alice? And when I complete the discussion, it won't be a complete shock. It will be awful. And I will not be able to do anything to mitigate that sense of doom. But at least there was a warning sign.
I think simultaneously running a code and trying to communicate with the family is one of the hardest but most meaningful things that we do as pediatric intensivists. And I would just love to hear maybe some of your preferences in the art of medicine. How do you incorporate families at the bedside when a CPR is ongoing, especially when you're really concerned this patient is not going to make it? Do you bring the family to the bedside while CPR is ongoing? You already mentioned having an individual who's dedicated to communicating with them. What are some other good best practices?
One other best practice that's relevant for the communication with that family is the patient English speaking or not? If it's the daytime or nighttime or your care model just allows for a live interpreter, if you can, then can someone please, just as important as getting these roles, you're on the chest, you have vascular access, you're the recorder, who's on getting the, again, not distracting away from the team, but if there's someone, oftentimes there's some extra folks, runners, right? Can one of you guys please get me the video translator, the audio translator, get them on the phone, this is the language. And then as soon as they're on, please let me know and I'll come out. Because again, at this point, the orchestra is playing without me. Gav is good, he's good without me. I'm going to walk out and start having that discussion because this becomes probably the most powerful part of the resuscitation, unfortunately. And so I will say to them out there, this is what's going on, and then I'll bring them in. And that'll be independent, Zach, of whether or not it's an arrest that unfortunately has a dismal outcome or a good outcome. This is my personal practice, and from what I've at least leisurely read through, the paradigm has definitely shifted towards having families at the bedside for these arrests to show them the dedication that the team provided, and most importantly, the dedication that they can say in their hearts, that they can live with some peace with, if at all possible, that they did indeed actually look for everything possible for that child. Because the minute they said that they don't want their child to be a DNR candidate, they were looking for something like this, that comfort in their heart, if that's even the word to use. Comfort's probably even the wrong word. But something to provide them some peace that I did indeed ask for everything to be done for that child. And I saw it firsthand. I saw the dedication to that team. So I'll bring them in as soon as I introduce the idea to them right outside the room. And it doesn't have to be outside the room. This is just my mental rehearsal of how it could look. It's just with all the chaos and the noise in the room, sometimes it's easier to, especially in the non-English speaking patients sometimes, to have that translator outside of the room seeing what's going on. Can I bring you in? That warning sign, every family's not the same either, right? Can I bring you in? Or I can bring you in so you can see what's going on with the team. We're doing the best that we can, but things are not looking good right now.
Yeah, that's really helpful.
Can you walk us through your approach to the post-CPR debrief? How do you like to structure it? And is there anything specific or in particular that you make sure that gets mentioned during that session?
The most important thing, and again, this is my being a simulation enthusiast as a debriefer, is making sure that everyone realizes this is a psychologically safe space. That the reason you must be coming and be interested in sitting with me for this debrief because you want to be better, we want to be better, and that's the basic assumption that we ascribe to in simulation when we have simulations and perform that debrief. And that is translatable to a clinical debrief as well. So the most important thing I want to get across is let's sit together because clearly you want to be better. This is a psychologically safe space. What you say here as an individual can easily stay here. Maybe what we learn here might not stay here because we want to be better as a program and as a system. But what we discuss as a group can be used to make the next outcome that's similar to this even better. So those are the things I definitely want to say. Basic assumption up front, psychologically safe space up front. And then the immediate debrief, again, there are different types of debrief, is what we call the hot debrief. And that hot debrief, ideally with the relevant stakeholders, ideally with all the stakeholders that were there, including, if possible, as the surgical subspecialists or other subspecialists that may have been relevant contributors to the arrest and the performance. Unfortunately, in the care models that most of us ascribe to, many of those stakeholders can't be there for the hot debrief. So we do the best that we can otherwise. And then what I try to tackle during the debrief after we've got the rules of engagement set aside are macro topics. And that will be probably, for the most part, relevant to your local institutions. Our personal ones are what went well and what could have been done better and why. What went well and why as well, because I said to you guys earlier in our talk that to make an assumption that what goes well will always happen well is inappropriate, because this might not be reproducible the next time. The fact that you guys were so good about lining up compressors, I don't want to take that for granted. What did you do to make that happen? And what happened exactly that we couldn't get the line of compressors together? Was there a systems flaw or practice-based flaw that we can improve on? Was it something about a medical management that went well or could have been done better? Practice-based, systems-based medical management and equipment. And then locally, we have a sheet that breaks up those big macro topics that we feed back to our resuscitation chiefs that we review in warm debriefs.
Well, great. Dr. Choudhury, this has been a great episode. So incredibly practical. Managing codes is something we find ourselves dealing with more often than we may like to in the pediatric ICU, cardiac ICU, all the above. I really have appreciated your ability to touch on some of the more controversial topics in this area.
I don't appreciate you putting me under the gun like that. My email's going to be full.
That's right.
I know.
Gosh. Yeah, of course, we're not providing medical advice. We're here just exploring topics, exploring this shared mental model that we even talked about in our episode today. Really appreciate you sharing all this information with me. And we're, of course, excited to pass that along to our audience. I did want to give you one last open-ended question. Really, whatever you'd like to share with us as we move towards the end of our conversation. It can be a plug for a resource, a conference to go to. It can be a key point to summarize, or really maybe something you enjoy in media.
Well, I think the most important thing is going back to why we all got into this in the ICU, in the cardiac ICU, and the PICU, the ability to embrace and enjoy these wins together as a team, and unfortunately suffer these losses as a team. And often we have these opportunities to practice as a team outside of the realm of the real patient. And I will put in a plug for simulation as an opportunity to do those kinds of things. In the world of burnout, I personally believe, this is my worldview, right? We have all worldviews. I personally believe you can mitigate a little bit of personal burnout if you feel like your performance was good, even if the outcome isn't. And simulation is still falling short to individually, directly change outcomes. But it could change the way we perform and the way we feel like we performed. And that can maybe impact the way burnout's natural history has to be. And so if you feel like you performed well on that day and you did your real best for that patient that day, you can say that if you have an opportunity to practice with your orchestra outside of the ICU with the real patient.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as replacement for medical advice. The views expressed during this episode by hosts and our guests are their own and do not reflect the official position of their institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com or find us on Twitter @CritPeds and @PedsCrit on Instagram for real-time show updates. If you enjoyed the show, please subscribe, rate, and review in your favorite podcasting application and share with your colleagues. Also, if you'd like to support the making of the podcast, please see the description for Venmo information and how to become a Patreon. Any donation will be appreciated. Thank you again for listening, and goodbye.
Oh, I have a quick closing question. Dr. Choudhury, do you play a musical instrument?
No.
Okay, I thought that maybe you did, and then we could close it with that. That's okay. You took me right back to orchestra practice.
Nope,
I love
I'm
it.
just a really bad shower singer. And I'm just waiting for my son, who I live vicariously through, to show me what a real orchestra player looks like.
Mm-hmm.
I was second trombone in junior high school, and I was not very good at it.
That is so great.
That's perfect.
That is so great. Well, as the director of this orchestra and our special guest soloist, Dr. Choudhury and Gav, thank you so much for being with us today. Very excited to share this with our audience.
Yeah, thank you so much for having me again.
Thank you, guys. Thanks,
All right.
thanks to my wingman, Gav.